a 10-year-old male presents with acute pelvic pain. I am showing you a coronal pelvic computed tomography scan, along with axial T2 fat saturated and post-contrast T1 fat saturated magnetic resonance images of the pelvis. Please describe the findings.
The computed tomography scan demonstrates a large, expansile lytic bone lesion involving the iliac wing with a thin remaining cortical rim. The magnetic resonance images confirm the expansile pelvic mass, showing multiple internal fluid levels and prominent enhancement of the internal septa.
What is your primary diagnostic concern?
The findings of a highly expansile lytic lesion showing multiple fluid levels on magnetic resonance imaging in a pediatric patient are highly diagnostic of an aneurysmal bone cyst, or ABC.
What is the physical and physiological basis for the fluid levels seen in this lesion?
The fluid levels represent blood-filled cavernous spaces where unclotted blood separates into cellular components and serum of differing densities under gravity, which is best visualized when the patient remains still for the scan.
What is the difference between primary and secondary aneurysmal bone cysts, and what is the most common precursor lesion?
Primary ABCs arise de novo. Secondary ABCs arise within another pre-existing bone lesion, most commonly a giant cell tumor, but also chondroblastoma, osteoblastoma, or telangiectatic osteosarcoma.
Why is differentiating a primary aneurysmal bone cyst from a telangiectatic osteosarcoma critical?
This differentiation is critical because telangiectatic osteosarcoma is a highly malignant bone sarcoma that also presents with expansile fluid levels. However, it features nodular malignant osteoid tissue, thick nodular septa, and metastatic potential.
Where are the most common anatomical sites for aneurysmal bone cysts in the skeleton?
The most common locations are the metaphyses of long tubular bones, such as the femur and tibia, and the posterior elements of the spine.
What is a classic nuclear medicine finding associated with this lesion?
On bone scintigraphy, it classically demonstrates the donut sign, which is a well-defined zone of intense increased radionuclide uptake at the active osseous periphery of the lesion surrounding a photopenic center.
Finally, what are your clinical management recommendations?
I recommend preoperative selective arterial embolization to minimize bleeding, followed by surgical curettage and bone grafting. Close postoperative monitoring is indicated due to a 10 to 20% recurrence rate.